Welcome to AETCM, the Emergency Medicine Channel.
Yes.
Today I'll be presenting a case of a 71-year-old male patient who presented to ER with unresponsiveness with urine and fecal incontinence following intake of Furidine, which is a carbamate. On initial 10-second assessment, patient is drowsy, not responding to commands. Primary survey, airway, there was gurgling sounds present. And at the same time, initially on 10-second assessment, patient is drowsy and not obeying. So he wanted to protect the airway from further any aspiration risk. So we had done a rapid sequence intubation.
What GCS you normally intubate the patient?
Basically, in case of only traumatic brain injury, only if the GCS is less than 8, we can intubate the patient. Or if there is a drop in GCS more than 2 points. Otherwise, in normal case scenarios, if we suspect any aspiration risk for that only, usually we intubate.
Less than which GCS?
Less than 8.
Okay. Which are the conditions you may not intubate the patient even when the GCS is low?
Severe metabolic acidosis patient who is trying to cope up with hypertension.
Hepatic encephalopathy patients.
Okay, hepatic encephalopathy,
post-ictal
state.
case.
Then one common condition you should tell. The most common condition in emergency room, patient come with coma, hypoglycemia. So these are the few exceptions you may not intubate the patient even when the GCS is very low. So you can easily correct it and the patient can be survived without ventilator.
And rapid sequence intubation was done. And after that, breathing wise, patient had bilateral scattered crepitations present with the V's. And the saturation on arrival initially on monitor it was 90% on room air, and respiratory rate was 26 on arrival time. After that, intubation, it has improved with 40% FiO2 to 98%. And tidal volume we are achieving around 380 to 400 we are achieving. And we had also given a nebulization of Ipravent was given. In circulation wise, pulse rate was 112 per minute, and BP was 110/60 millimeters of mercury. And disability wise, GCS was initially.
Why you selected Ipravent? What are the reasons?
Because salbutamol, if we give again, the heart rate can increase further. Already patient has 116 heart rate, so any further increase we wanted to avoid.
Anticholinergic facilitation.
It has to be the answer, because you know that it's a OP compound poisoning. You want to give atropine or atropine derivatives like glycopyrrolate or atropine, and ipratropium bromide also come in same category, and it can be useful in COPD also, better than asthma. And like you told, heart rate also can increase when you are giving salbutamol. Why in this one OP poisoning heart rate increases? Normally you expect a low heart rate.
Usually there are two effects in OP poisoning. It can be either muscarinic effects or nicotinic effects. So based on which receptor is getting stimulated, the response. If it is a muscarinic, it will be bradycardia and hypotension. If it is nicotinic receptor, it will be tachycardia and hypertension response.
So how much percentage patient can present with tachycardia in OP poisoning? 20 to 30%. 30% patients can, 20 is okay. 20% of patients can develop tachycardia instead of bradycardia in OP poisoning. That is because of this nicotinic effect. And
further, disability wise, on arrival GCS we had assessed that time it was E1, V1, M5. So around 7 out of 15 score we had. And pupils we examined, it was showing dilated pupils, 4 mm, not reacting to light.
What do you think the reason is?
Actually, the patient was treated from outside hospital with atropine. They had initially given 2 mg and they had hiked up to maximum for atropinization. They took around 16 mg.
Okay. What is the duration of atropine in terms of heart rate, in terms of secretion, in terms of pupil reaction?
Duration of action.
20 minutes.
Very
Tell, you have to tell. Your emergency doctors should know. 1 to 2 minutes. Atropine acts only for 1 to 2 minutes in heart rate and heart. But whereas in pupil, it will be prolonged action. It may stay up to 6 to 12 hours, up to one day it can sometimes be there. Okay, there is a main difference. If your heart rate within 3 minutes, it come back to normal. Okay, if you give atropine, it acts only for 3 minutes maximum. That's why we give atropine as an infusion. Okay, to give a sustained action.
Right.
But the pupillary reaction will persist for a longer period.
And then GRBS was 154. Exposure-wise temperature was 98.8 degree Fahrenheit. And adjuncts of primary survey, we
What
had
do you
taken
expect in OP poisoning temperature?
temperature usually it will be on lower side.
It will be mostly on the lower
side.
But when you give atropine,
Atropine will be go to
it will increase.
hyperthermia.
Okay.
Adjuncts of primary survey, ABG was taken which showed pH of 7.239, PCOT of 63.7 and POT of 62 and bicarb of 26.3, lactate 2. ECG taken was showing sinus tachycardia only. QTC was 440.
Okay.
And secondary survey, we have patient, 71-year-old male patient, was last seen normal at around 8 p.m. one day prior to our admission here. And next day early morning, on the day of admission, early morning patient was found unresponsive beside his bed with fecal and urinary incontinence and sweating, and he was taken to outside hospital. There they gave history of intake of Furodan was given, and atropine 2 mg up to 16 mg was given, and they started infusion and they referred here. And there was no other history of any seizures or any trauma history, alcohol ingestion, vomiting or breathlessness. Patient no, not allergic to any medications. And on patient is a known case of OAD, obstructive airway disease and hypertension. Last food intake was around 14 hours back.
How do you know that it is obstructive airway disease? You have any evidence?
Documentation from outside hospital
What
is there, and also smoker history.
Smoking is not OAD. You are telling
Obstructive airway disease.
Or not OSI. Okay.
No, not OSI.
Okay.
BPG wise,
Maybe.
PCO2 15 by carbon
60 years,
83,000 chronic.
Okay. Chronic
Hyperinflated
with
lungs,
compensation.
Hyperinflated lungs.
Okay.
And examination wise, chest, as we said, entry was bilaterally equal, but there were scattered crepitations present, and also wheezing was present. And CVS wise, SNS was normal, no murmurs were heard. CNS wise, as we said, GCS of 7 out of 15 with pupils dilated. And GIT wise, abdomen was soft. And we had taken an X-ray, portable X-ray was taken, and it showed bilateral scattered infiltrates was present.
Okay.
And also the lungs are hyperinflated lungs was seen. And lab wise, we had sent.
What are the X-ray findings of COPD?
COPD will have hyperinflated lungs, then
do you know
flattening of diaphragm.
Flattening of diaphragm.
And tubular heart.
What will happen to the space of
Spatially.
wide? Okay.
And for this patient, we actually had presented after around 12 hours, and last seen normal at around 24 hours back.
Okay.
So we didn't. They had placed ice tube in outside hospital, and no samples were sent here.
Okay.
So here we didn't do any gastric lavage or activated charcoal because beyond the time frame. And
what is the time frame for activated charcoal?
Within 4 hours.
1 to 2 hours.
In case of normal poisons, 4 to 5 hours, but if it's a sustained release kind of thing, repeated,
We can give
So
multiple
normally up to 4 hours you can give maximum, but if the patient has taken large quantity, or if the patient has taken an
extended release formulations, we can.
And remember, a patient who is having diabetic gastropathy, they also will be having less movement. If they have taken alcohol, all these conditions you can give extended regime. Okay.
Or multi-dose
activated regime.
And
what is the dose of activated charcoal?
1 gram per
1
kg,
gram per
50 to 100 we can. And if it is a multi-dose, every 4th hour we can keep on giving 50.
Okay.
And here we actually had collected blood and urine samples. Gastric aspirate also we had taken, but already this much time has passed. And also
Cholinesterase
we have
level?
sent for we have taken serum cholinesterase levels also, and we had sent for the toxicology analysis for the levels of the carbamate levels, and also for alcohol levels also. And here also in lab wise CBC we had taken, which showed at raised total counts, 15,000 total counts, CRP of 60.
Okay.
So as aspiration component also we were suspecting. So we started.
Do you think that after aspiration CRP and this one will increase like that? Yes or no?
It's almost 24 hours.
Yes or no? You have to tell yes or no.
Yes,
Is it possible?
One
Aspiration alone will not produce any increase in this one. Aspiration induced pneumonia. Either it is chemical or bacterial, can produce sometimes elevation of inflammatory markers. Because every day we will be aspirating. Aspirations are known in normal people. So if that creates a pneumonia or something like that, it can increase.
So on arrival to our ER, actually we had also changed the clothes and decontaminated the patient. And after that we had actually the infusion was going on. So we calculated requirement. They had last given 16 mg atropine, and there are crabs persisting. So almost we took around 20% of the dose and planned for infusion. So it came around 3.2 gram. Since the crabs and all was persisting, we just started at 4 mg per hour. And we then further observed half hourly to 1 hourly monitoring was done. That time secretion started to clear.
So in OP poisoning, which is the end point of atropine?
Endpoint is bronchoria clearing dry.
Not the heart rate,
That is a normal.
That all can be there in 1 or 2 doses of atropine itself. But the end point of atropinization in OP poisoning, that is different from the end point of atropine in a normal person. But in OP poisoning, it is secretion dryness. But only thing is old age, you can get some crepitation as a normal phenomenon. So it will be very difficult to assess these type of patients.
And then we started at 4 mg per hour, but the patient was getting agitated. And agitation was there. So intermittently we had given midas.
So what do you do if the patient develops agitation when the patient is on atropine? What do you do?
Usually we have to see for any signs of atropine toxicity first of all.
This is atropine toxicity. So what do you do?
We have to stop the infusion for 1 hour, and we have to restart at 80% of the dose and see again.
One is reduce the dose.
Reduce the dose.
But if the patient, suppose the patient has taken very high dose of OP poisoning, not like this patient, high dose of OP poisoning, and when you are giving high dose of atropine, he has developed agitation. What do you do?
You can give benzodiazepines, midazolam, or
you have to add there are 2 ways. One is entirely change the atropine to glycopyrrolate and give. Only problem is glycopyrrolate will not cross the blood-brain barrier. So if the patient has developed OP-induced CNS damage or CNS effect, then you have to give small dose of atropine with high dose of glycopyrrolate. So you can either switch completely to glycopyrrolate and continue the same dose, or reduce the atropine dose to minimum and add glycopyrrolate to control the other peripheral problem. Okay, so you have to try that. Diazepam is not the treatment for atropine overdose or atropine-induced toxicity. You have to reduce the atropine, and if you require, you add glycopyrrolate.
So after that, we had actually started the patient on antibiotic augmented, and clindamycin was started for aspiration pneumonia coverage. And after that, actually, patient was
augmentin cover aspiration pneumonia. Yes or no?
Yes.
Covers. There is no requirement of clindamycin as a first step when you are treating aspiration pneumonia. You can simply start augmentin. That itself will cover anaerobes. Okay. But if there is a severe pneumonia, toxicity, then you have to add clindamycin.
And after that, patient after admission and monitoring actually had episodes of hyperthermia. The temperatures were going up around 102 degree Fahrenheit.
What do you do there? What all things you have to do when the temperature is very high? What all things will come to your mind?
So one atropine toxicity.
Responding is treatment.
Atropine toxicity. We have
first
to
is atropine toxicity. That is the correct thing. Then
reduce dosage.
Atropine and the toxicity, that you have to reduce the dose.
Then secondary to the aspiration pneumonia.
Aspiration pneumonia is developing an infection. You have to treat with antibiotic. Third one.
Any other drug use like serotonin syndrome, hyperthermia?
You have to think about NMS serotonin syndrome. You have to check the creatine kinase, and if that is very high, you have to treat according to that. So 3 things you have to think in this type of patients. Okay.
And this patient actually we had a reduced dosage for this patient and made it 1 mg per hour.
Okay.
After stopping for some time.
Okay.
And also we had planned to start on glycopyrrolate also. We started around 1 mg per hour infusion as it. We have started one ampule contains 0.2 mg. So around 5 ml 1 ml is 0.2 mg, so 5 ml per hour we had given infusion of glycopyrrolate. And also these two mainly we started. And further patient was agitated, still agitated, and we had started on dexmed infusion also.
Okay.
Dexmedetomidine was started, and also there was also BP, progressive BP falling was there. So we had started on noradrenaline support also. Hypotension episodes were there, and we had started on noradrenaline, and now tapering down noradrenaline, and secretions, everything is now clearing up, and further waiting for the results.
Okay. Now COPD on ventilator, that is another issue you are going to face. What are the problems of COPD on ventilator?
COPD.
Here you are intubated for something else, not because of COPD. To protect the airway, you have ventilated the patient. But soon the patient will become ventilator dependent. That is the main issue. You will not be able to wean off this patient from the ventilator if it crosses 48 hours. It will be very difficult to wean this patient from ventilator.
And hypoxic drive also has to be maintained.
Hypoxic drive? What is the reason for that? If you put a patient on ventilator who is having COPD, what happens?
So basically, normal patient carbon dioxide is the drive for respiration, but in this patient's SPCO.
Normally, what is our drive? We assume that we are normal.
SPCO also is
H plus.
You run for half an hour. Hypoxia is the drive. For a normal person, hypoxia is the drive. When you run for half an hour, you breathe very fast. That is because you are developing hypoxemia. COPD patient, it is always hypoxemia, and their carbon dioxide levels are very high. Okay, so the body has changed that oxygen to carbon dioxide, switched, and whenever carbon dioxide levels are increasing, body will try to breathe fast. Okay, now on ventilator you are correcting everything normal, and patient's CO2 is normal. So the hypercarbic drive is removed. Okay, so what will happen? You are removing that drive at all. There is no drive. Previous drive was removed. Current drive also. That's why now patient is not triggering. You can see ventilator. Patient is not at all triggering. That means he is getting the dependence on ventilator. So we have to correct it fast and wean off the patient from ventilator. Otherwise, he may go to permanently, like long-term dependence on the ventilator. What else you will take care in this patient other than your OP poisoning management?
You have to take care of DVT prophylaxis.
Okay, that is a must.
It started Clexane.
Okay.
Okay. Started.
What are the other phases of OP poisoning? This is Carbamate. Carbamate within 48 hours.
Reversible action.
Okay.
Around a half-life of 30 to 40 minutes only.
Okay.
And usually reverses within 1 to 2 days.
Okay.
Because of the reversible activity on the acetylcholinesterase.
So you give only atropine?
So only atropine is there is a role. Oximes there is no role.
Okay.
Oximes can also worsen. The transient worsening of acetylcholinesterase inhibition can occur.
Okay.
So that should be avoided. And only mostly atropine infusion is only necessary.
Okay.
And
other phases of
then in OP poisoning wise we have intermediate.
Here it is
3
not
phases
there.
actually.
Okay. Here it is not there.
It's not. 3 phases we have actually. One is the cholinergic phase, acute cholinergic phase, followed by intermediate syndrome.
Okay.
Intermediate syndrome occurs around 2 days later, or 3 to 4 days. It can get delayed. And third one is the delayed polyneuropathy phase.
What is this intermediate syndrome?
So intermediate syndrome actually occurs because of the fat soluble OP compounds. They get released later if you don't start oximes on time.
Okay.
It can get
not only when you take large quantities, some will be deposited in the fat. After 48 hours, it will slowly release.
Come into the and also
what is the
they
treatment
have
of choice?
mainly this muscle paralysis, weakness and fasciculations. So food drop
is in the last phase. He can get foot drop, but that occurs mainly in the late phase.
So there will be
muscle weakness is the predominant problem.
Muscle weakness usually bulbar neck muscles, proximal limb muscles, lower limb also can get.
What is the treatment here?
Usually
oximes or atropine?
Oximes are actually for nicotinic because atropine doesn't have any nicotinic receptor action, only muscarinic receptor action. Oximes have both nicotinic and muscarinic actions. Okay. So for muscle weakness and all, mostly oximes will only help the patient. And then if any respiratory paralysis is there, we'll have to intubate and ventilate the patient.
Last phase?
Last phase is delayed polyneuropathy phase. In that there is degeneration of the myelinated nerve fibers.
Okay.
So these patients, they will have symmetrical flaccid paralysis.
They have
Mostly
mainly neuropathy, then myopathy. Myopathy is the second phase. Neuropathy is the third phase. They have predominant foot drop. Okay. Foot drop is a classical finding you see, but if you take an NCB, then you'll get a lot of other findings. Sensory and motor. It's a motor weakness. Foot drop. Foot drop is a motor weakness. Okay.
And then sensory disturbances can be there. Then also reflexes can be absent. Deep tendon reflexes will be absent.
Why they are absent?
That
It's a basic, simple MBBS question. Why deep tendon reflexes are absent in delayed polyneuropathy?
Because the myelinated nerve fibers are getting degenerated, so the efferent pathway is lost.
That is because one of the component of your reflex arc
is
is lost. That's why. Okay, you will get absent reflexes.
And usually it occurs around 1 to 3 weeks.
Okay.
Due time.
Okay. Those who are having long-term exposure to OP poisoning, like farmers, they also can have this delayed polyneuropathy. They may come with acute symptom, but initially itself they can have. So here in our state it is not there, but other states you can see many patients, they already have foot drop or minimal foot drop will be there. So that we have to keep in mind. Here nothing will happen. So now how do you discharge this patient after once you wean off from ventilator? What do you do? It's a COPD patient. Is this carbamate will either soon will disappear or he may go to ventilator acquired pneumonia. Once you recover from ventilator, how do you discharge this patient? What are things you have to take care? Plan for discharge of a patient who is having COPD.
So vaccination.
Vaccination should be given then. Now, how do you advise the patient? You have to give some treatment and discharge. Protein-rich diet. Diet is the main thing. The protein-rich diet.
Prophylactic
Antibiotics.
Azithromycin prophylaxis 250 mg alternate days for 6 months. Then spray.
Nebulizer or inhaler. We can give
Metered dose inhalers. Which one you give?
We have to give long-acting beta agonists like salmeterol or formoterol, along with steroid also, budesonide. We can.
Ipotropin bromide, triatoprim
bromide
that should be given. So formoterol with steroid with triatoprim bromide could be given. Like you told, high protein diet, high potassium diet, low carbohydrate diet, vaccination. Low carbohydrate diet is for what?
Prevent PCO2.
Prevent PCO2 retention. How it produces PCO2 buildup? As a basic physiology. If you eat more carbohydrate,
like PCO2,
more CO2 will be produced. CO2 and water. So you have to reduce the carbohydrate intake, you have to increase the protein intake, you have to increase the potassium intake, then vaccination should be given. Respiratory physiotherapy should be advised. All these things we have to take care. Okay, anything else you want to tell? Anything else? Nothing. Thank you.